Hi, how are you? My name is Eric Albert, and I'm here to do my final presentation. The topic that I'll be covering today is what is the most rapid and accurate clinical tool to recognize sepsis, in particular in the emergency department. Just to give you a little background information on myself, I started in the medical field about 15 years ago. First, I was an EMT, then worked my way up to be a paramedic, working in the 911 system in New York City. Became a critical care paramedic working in a NICU, and currently I am an ER nurse. I worked for about 4 years in New York City, in New York Presbyterian, and the ED, and about a year ago moved to Jacksonville, Florida, and work at Baptist South in the Baptist healthcare system. This is the outline of the presentation. First we'll talk about the problem, then my PICO statement, data collection methods and strategies, the evidence that I found, the change model that I'll be using to implement my change, some dissemination strategies that I'll be implementing, and finally the conclusion. The problem that I came up with is mortality in septic patients increases significantly the longer care is delayed. So having a clinical tool that can rapidly and accurately identify potential septic patients, the sooner sepsis bundles can be initiated. The reason that this is important is because every hour the care is delayed in a septic patient, it increases mortality rates. Sepsis has a mortality rate as high as 30%, but still lacks a valid diagnostic test. The problem with sepsis is there's not a 100% or a universal definition for it. In general, we do know that sepsis is due to an infectious process and is the overreaction or toxic response to an infectious process that causes tissue damage, organ failure, or even mortality. Due to the reimbursement rates from insurance, from the Center of Medicare and Medicaid, and Surviving Sepsis campaign, all these core measures are put onto the ED in order to get the reimbursement rates and increase or decrease mortality rates. As you can see here, every hour antibiotics are delayed, mortality rates in septic patients increase by 7.6%. The problem with realizing or diagnosing or detecting sepsis quickly in the emergency department is that 53% of patients with severe sepsis or septic shock will not present with evidence of an infection in triage. So we're not recognizing these patients fast enough, but yet we're being held to a standard or an expectation to initiate care more rapidly. So the PICO statement that I came up with is, in adult patients, does the early warning score identify septic patients that are at a higher risk of death within 30 days more accurately than SIRS or qSOFA in an acute care setting? Right now, probably the most used clinical tool or scoring system is SIRS. The other one is qSOFA, and the other one is the early warning score. And I'm going to kind of go over the benefits of all of them, which one in particular has the most evidence of being the most accurate, and then also which one is the most rapid, and especially identifying 30-day mortality rates in septic patients. Some of the key words that I used in collecting data were sepsis, news, news2, Muse, SIRS, qSOFA, emergency department, ICU, and mortality rates. News is just an acronym for the National Early Warning Score, and then there's been some variations in the scoring system since it was started. News2 is just the updated of news, and then Muse is one of the most used early warning scores being implemented nowadays. It is popular in Jacksonville, Florida, and I'll get a little further or a little more into what I am doing currently with the Muse score in my own hospital. The inclusion criteria that I used was articles that were related to the emergency department, the ICU. It had to be written in English, had to have full text, it had to be peer reviewed, pertain to adult patients, pertain to sepsis, have to be within, had to be current from 2015 or present, and had to include mortality rates, especially within 30 days. Excluding criteria had to do with non-critical units that septic patients were admitted to, outcomes not related to sepsis, articles that included pediatric patients. If it was published earlier than 2015, it was excluded. If it wasn't peer reviewed or did not have or include the early warning score. This is my Prisma, kind of how I got the articles that I used for my research. As inclusion and exclusion criteria were applied, kind of breakdown here of how I kind of narrowed down to the most significant articles. In the end, there were 6 articles that were really significant to all the criteria that I needed, and then some other ones that pertain to certain aspects or kind of just supported evidence. Now we'll get into some of the evidence that I found in the articles. Overall, the news had a higher prognostic accuracy than SIRS or QSOFA. Pretty much across the board of any article that I found, that had tended to be the consensus that, especially pertaining to mortality rates in septic patients and identifying septic patients rapidly, QSOFA outperformed both SIRS NEWS outperformed SIRS and QSOFA. At the bottom here, you can see some of the statistical analysis methods that were used. In particular, you'll see in the upcoming slides the ROS curve or ROC curve. Here's the ROC curve from one of the articles that I used, and it kind of just goes to show you how NEWS outperforms both QSOFA and SIRS when it comes to specificity and sensitivity. This just goes over predicting 30-day mortality rates and 10-day mortality rates in septic patients using all 3 of the scoring tools. The problem with SIRS and QSOFA is there are, at lower scores, they have higher sensitivities or specificities, and then as the scores get higher, you kind of get the inverse. But neither one of them has a intermediate or solid or strong agreement between being sensitive and specific. And in NEWS, you'll see that between a certain score, mostly between a score of 4 and 8, there is a strong or a high sensitivity and specificity, so you know that you are treating the right condition and that the patient is also at risk for death. This is another article that I used, and it kind of just illustrates the same thing. As you can see here, that SIRS has a high sensitivity with some of the lower scores, and then a high specificity as the scores get higher, but there's really only a score of 2 that it kind of has that match. And with QSOFA, you get the inverse as you get with SIRS, where it has a high sensitivity or high specificity, but there's really no match. It's just flipped compared to the the score. And as you can see down here with NEWS, and this is kind of what we're targeting when it comes to the ED, is we need something that's rapid and gives us a reliable tool to use to identify septic patients that are at risk for death. Between the score of 4 and 8, you can see that it has a high sensitivity and high specificity, in particular to recognize septic patients and sepsis mortality. This is the main idea matrix, and it just kind of goes over the main ideas of the stuff that I was looking for. And the first thing that I was looking for was for rapid identification. And these are 4 articles, 4 of the 6 articles, and it just kind of goes over what each one found. News can rapidly detect patients at high risk for deterioration, patients that require ICU admission, or death within 24 hours. News has a rapid assessment tool that is comprised of 7 parameters and should recognize patients that are septic and at risk for death rapidly and could be implemented at triage or pre-hospitally. And this is kind of really important, especially for the purpose that I did the research, is I needed something that was rapid and something that was sensitive and specific, and News 2, and News all fit that criteria. The good thing about the early warning score is that for ED nurses in particular, is that it only uses the vital signs that you would get in any triage. The only thing that it adds is an AVPU, which for people that aren't familiar with that, what that stands for, it's a mentation acronym that stands for patients that are alert, responsive to verbal stimuli, responsive to painful stimuli, or unresponsive. That's where you get the AVPU from. So any nurse that's getting basic vital signs and can assess a patient's mentation can get a quantifiable numeric value that tells you how likely somebody is to be septic, and how likely, or kind of identify how at risk they are for deterioration and for mortality. The other 2 articles kind of go into the same thing. Early recognition of sepsis reduces mortality rates due to rapid implementation of sepsis bundles. And a notable advantage of News is that it does not rely on laboratory values and could calculate at the time of triage. And that's kind of important when you talk about SIRS. SIRS is very sensitive, has a high sensitivity to recognize septic patients. The problem with SIRS is that it relies on lab values, which could be timely and delays care. The next main idea was mortality rates. 40% of patients that were expected to die within 90 days based on their News scores died within 30 days of News scores of 5 or higher. And across the board, and as you can see on the 3rd article, that a score of 7 or greater is an optimal threshold for predicting in-hospital mortality. So as the numbers get higher, or the score gets higher, you're at more likelihood for mortality. The problem is when you get kind of above, let's say, from all the research, above 11 or 12, depending on which article you're reading, is that you kind of get away from maybe sepsis, and that these patients are just at higher likelihoods for deteriorating and high risk of mortality, just not necessarily from sepsis causes. And as you can see in the last one, where scores between 4 and 8 kind of puts you in that really good and reliable range to say that patients both have sepsis and are at risk for death. And the last one is the comparison between News, SIRS, and QSOFA. And just not kind of go into further detail, but each one, as you can see, just says that News outperforms both QSOFA and SIRS at identifying septic patients and sepsis patients that are at high risk for mortality. This is the change model that I will be implementing, and it is called the ARCC model, and that stands for Advancing Research and Clinical Practice Through Close Collaboration. The best thing about this is that it uses evidence-based champions and coaches to implement change. And really what it does is it kind of changes the whole culture of an organization and makes evidence-based practice part of the culture and part of the expectations of the hospital. And it educates nurses and staff as to why evidence-based practice is important and the practices that we're implementing, kind of the science behind it. So it makes, so you're not just having people blindly be compliant to policies and procedures without knowing why. And, the more people are educated as to why they're doing things, the more likelihood they will be adherent to the expectations. This is some of my dissemination strategies on a local level, and something that I wanted to talk about is that right now at my hospital I am currently in something called the Excel program, which is a year-long process that that can be used for anybody that wants to implement evidence-based practice, nursing research, or performance improvement within our hospital system. And one of the downtown assistant managers and I are currently in the process of getting news put into our triage process to identify septic patients and to initiate sepsis protocols. Because everything that I'm doing pertains to the ED, the publications that I would be interested in getting my research my research and my Excel program published in is the Journal for Emergency Nurses, going through the Emergency Nurse Association. Currently, I've been talking to other local hospitals, meeting with their shared governance, and this is just a good way to get information regionally spread, and meet some other people from other hospitals and get some feedback and see how they're doing things and how you can implement some of the stuff that they're doing, and also get some of the practices that are working in your hospital, see if it can improve their performances. So my recommendations right now are to implement a new clinical tool into triage process to detect patients that are at high risk for septic shock and death. 2, new scores of 4 or greater should be high priority patients, and sepsis bundles should be initiated. And anyone with a new score of 7 or greater should be admitted to the ICU. Anyone with a new score of 7 or greater really should be one-to-one care. And as you can see, this little illustration down here just kind of shows the faster we act, especially when it comes to sepsis. And people that are that are at high risk for deterioration, the better the outcomes patients will have. And one thing I also want to emphasize is that the comparison between QSOFA, SIRS, and NEWS is that NEWS had the greatest agreement between expected outcomes and observed outcomes. In conclusion, NEWS is a scoring system that incorporates vital signs that are part of any basic triage and converts vital signs into a numeric value that can expedite care and clinical decision making. NEWS is the quickest and most accurate clinical tool to recognize septic patients. Delaying care in sepsis patients increases the likelihood of death and longer hospitalization. Implementing NEWS in the emergency department will save lives with greater precision and more rapidly than SIRS or QSOFA. The quicker septic patients receive treatment and get admitted to the appropriate unit, the better chance they have at life. In the end, that's our jobs as nurses and healthcare providers, is to give patients the best chance at life. And implementing the NEWS into the triage process and a tool for nurses to use gives us a more accurate and rapid assessment tool to recognize septic patients that are at a high likelihood of deteriorating quickly. These are my references. I hope that this was insightful, and I hope more ERs, organizations, and emergency room nurses can use this tool to help them provide better care. Thank you.